To see if NAFLD in HIV is different from primary NAFLD in the general population, we need to have some concepts of NAFLD per se. So NAFLD, non-alcoholic fatty liver disease, is the ectopic accumulation of lipids in more than 5% of hepatocytes. And in 20 to 30% of patients with NAFLD, there is some degree of necroinflammation, and it's called non-alcoholic steatohepatitis. And patients with non-alcoholic steatohepatitis can progress for fibrosis, cirrhosis, and its complications. Most patients are slow progressors, but a small subset of patients will progress more rapidly to cirrhosis. Worldwide, the prevalence of NAFLD is 25%. We know there are several high-risk groups with higher prevalences, always associated with the metabolic syndrome. For instance, type 2 diabetes mellitus patients, patients with obesity, with dyslipidemia, have a much higher prevalence of NAFLD. And we know that NAFLD has a role in the survival. We know that patients with NAFLD survive less than patients without NAFLD, and the causes of death are mainly cardiovascular, and liver disease is only the third cause of death. Most importantly, we know that what dictates the hepatic and the overall prognosis of patients with NAFLD is the degree of hepatic fibrosis. So what about patients HIV positive? We know that liver disease is the second non-AIDS-related cause of death among patients with HIV, and we know that the burden of NAFLD is increasing with the increase of the metabolic syndrome and with the advent of highly efficient therapies for viral hepatitis. What are the cyanogenic mechanisms in HIV patients? So, as in the general population, the metabolic factors are the most important ones, so diabetes, obesity, hypertriglyceridemia, visceral adiposity. Alcohol is important for hepatic steatosis, and we know that HIV patients tend to have higher alcohol intake than non-HIV, so at least 50% of HIV patients drink some alcohol, and up to 50% are heavy drinkers. The HIV itself may have some steatogenic mechanisms. We know that HIV probably promotes the metabolic syndrome, and this is an epidemiological study in which patients with higher viral load would have more constituents of the metabolic syndrome and more prevalence of metabolic syndrome. HIV may have a direct diabetogenic effect with the mitochondrial damage in the adipose tissue that will lead to insulin resistance. It can have a direct steatogenic effect with increase of transcriptional factors that modulate the lipid metabolism, and it has been shown a direct fibrogenic effect with HIV activating hepatic stellate cells. And then we have the antiretroviral therapy, which may have some steatogenic mechanisms too, by promoting lipodystrophy, in which there is a loss of peripheral fat and an accumulation of more metabolically active central fat, and we know that some drugs are prone to it. Some drugs also lead to insulin resistance and diabetes mellitus by unknown mechanisms or even by some known mechanism. For example, some protease inhibitors inhibit the glucose transporter GLUT4. And some antiretroviral therapies, like for instance stavudine, can produce mitochondrial toxicity with a specific form of steatosis in the liver, which is microvesicular. Fortunately, the newer drugs seem to be more metabolically friendly, so probably less prone to induce steatosis. So we know that in primary NAFLD, dysbiosis and bacterial translocation from the gut are important in inducing not only steatosis, but more severe forms of liver disease. And HIV patients are at a particular risk of presenting gut dysbiosis with altered gut association lymphoid tissue. Genetics. We know that in primary NAFLD, PNPLA3 variants are associated not only with steatosis, but also with more aggressive forms of liver disease. There are not so many studies in HIV-positive patients, but small studies in co-infected HIV-HCV patients suggest that the presence of this variant of PNPLA3 also associates with severity steatosis, although this study failed to find an association with more severe liver disease. Co-infection with hepatitis C virus. We know that hepatitis C virus is associated with two types of steatosis. One that is called viral steatosis because it is a direct effect of the viral proteins inducing steatosis. It is much more frequent in genotype 3. It does associate with viral load and reverts with viral eradication, but it does not associate with progression of liver fibrosis. And then we have metabolic steatosis, which is associated with the metabolic syndrome as primary NAFLD. We know that HIV may promote the metabolic syndrome. For instance, it can induce insulin resistance and diabetes mellitus, or at least promote it. And we know that this type of steatosis does associate with progression of liver fibrosis and worse prognosis. So what is the prevalence of hepatic steatosis in HIV-positive patients? In the pre-treatment era, there was considered to be a very, very prevalent condition up to 80% of patients, and it was associated with malnutrition and opportunistic infections. In the post-ART era, early on, it was considered to be very frequent, and it was related to a drug-induced liver injury, as I explained before. Fortunately, with the newer, more metabolically friendly antiretroviral agents, it seems to be lower, the prevalence. So I'm presenting you here a recent meta-analysis that showed a prevalence of NAFLD in HIV-positive patients of 35%, which seems to be higher than the general population, which is agreed to be 25%. But we need to be careful with this number because we know that depending of the diagnostic tool to diagnose steatosis, the prevalences of steatosis in this population has been extremely variable. So there are at least two studies that compared two similar populations, one with HIV and the other without HIV, and compared the prevalence of hepatic steatosis in those. And both studies found that HIV patients actually had less hepatic steatosis than patients without HIV. And HIV was even an independent factor protective of hepatic steatosis. So maybe it's not so prevalent as we thought. What about co-infection HIV-HCV? Is it really a synergic association? So several studies did show a higher prevalence of steatosis in co-infected versus HIV monoinfection. However, a meta-analysis did not confirm that. It showed no higher prevalence of hepatic steatosis in co-infected. And a recent cohort study also did not find an increased prevalence in co-infection. Also, a recent study, in fact, did find a lower prevalence of steatosis in either HIV mono, HCV mono-infected or co-infected patients as compared to non-infected subjects. What are the factors associated with NAFLD in HIV patients? So I'm bringing here the same meta-analysis in which they found that it really were the metabolic factors as in the general population that associated with an increased risk of hepatic steatosis. Though they did found some association with viral factors like CD cell counts and duration of ART associated with the presence or not of steatosis. In the co-infected patients, again, the metabolic factors seem to be the most important ones in determining the prevalence of steatosis, but we know that probably some drugs, like for instance stavudine, are associated with higher risk of developing steatosis. So this study compared patients with NAFLD, either HIV positive or negative, and they found some differences in the HIV positive population. For instance, they tended to have higher triglyceride levels, they tended to have less BMI, less weight, less body fat percentage, and higher physical activity, which suggests that probably there are some factors related to the virus here. What about significant liver disease in HIV patients with NAFLD? Not just steatosis, but NASH and fibrosis, that is what dictates the prognosis. So in this meta-analysis, we did find a higher prevalence of NASH in these patients, as it would be expected for the general population, as well as fibrosis prevalence in HIV patients. This is a matched case control study in which they've compared NAFLD, primary NAFLD with HIV-associated NAFLD, and they did found that patients with HIV tended to have higher levels of aminotransferases, higher levels of triglycerides, higher prevalence of NASH, and of cellular lesion like acidophil bodies. Here, regarding the presence or not of NASH, the HIV duration was associated with higher prevalence of NASH. What about factors associated with fibrosis? Fibrosis is what dictates the prognosis in NAFLD. So in HIV monoinfected patients, again, it were the metabolic factors that associated with a higher risk of having fibrosis. Though in a study with non-invasive methods to evaluate fibrosis, they also found detectable HIV viremia has a risk factor for having fibrosis. Now, regarding a longitudinal study with the live HIV cohort, in which they did find the similar prevalences of steatosis in HIV mono and co-infected patients, they did found that whereas in patients with HIV mono infection, the risk of worsening of steatosis was higher than in the patients with co-infection with HIV. Regarding fibrosis, the same study, they did found much higher prevalences of advanced fibrosis in patients co-infected with HIV, but there were clearly different risk factors for progression of fibrosis in HIV monoinfected and HCV co-infected. In the monoinfected group, the presence of steatosis did associate with an increased risk of progression of fibrosis, whereas in the co-infected, the viral effect was so important that the steatosis did not have an effect in this group. So what about NAFLD in non-liver outcomes in HIV? So we know that in the primary NAFLD, the presence of NAFLD associates with an increased risk of cardiovascular disease. Does that happen too in HIV patients? So we cannot tell yet, but there is a small study that suggests that because patients with a higher coronary calcium scan in the scan would have a higher prevalence of NAFLD. Regarding mortality, I did only found a very small study which could not find an effect of having steatosis in mortality in HIV patients, but this is a very, very small study. Lastly, regarding the treatment of NAFLD. So in the general population, we know that all patients should be submitted to intensive lifestyle intervention with diet and exercise changes, maybe considered bariatric surgery if morbid obesity is present, because those patients are at risk not only of developing worse liver disease, but also of dying of cardiovascular disease. And also we know that losing weight will have an effect in NAFLD, NASH, and fibrosis. For patients that already have fibrosis, those are the patients that worried us most, because those are the patients at risk of developing late-stage NAFLD. There is still not a good therapy for them, though there are some data in vitamin E insulin sensitizers that do not stop fibrosis progression, and there are several drugs now being studied. The most advanced ones are obeticholic acid and elafibranor, and of course patients with cirrhosis, we should screen them for HCC and esophageal varices. But what about NAFLD in the HIV patient? So we know that HIV suppression and high CD4 may decrease steatosis, so we need to treat them aggressively for its HIV. We should avoid drugs like stavudine and didanosine because they are steatogenic, and we should choose more metabolically friendly HIV drugs. We should treat HCV patients, and there are at least 3 drugs that are being tested in the context of HIV. So one of them is Tesamoreline, which is a synthetic growth hormone release hormone that specifically targets the adipose tissue, and it's already approved for excessive visceral adiposity in HIV. There is a very small study in which they gave 6 months of this drug, and they did find a decrease in liver fat content. And there are 2 studies in HIV patients with NAFLD ongoing right now. A RUNCall, which is a fatty acid bile acid conjugate that decreases fatty acid synthesis and increases hepatic cholesterol efflux. There is also a small randomized control trial in NAFLD in which there was a decrease in liver fat, though they could not find effect in metabolic profile or even liver enzymes. And there is an ongoing trial in NAFLD patients with HIV. And lastly, enicriviroc, which is a CR2/CR5 antagonist that inhibits HIV entry in the cells. It has been shown to have an anti-fibrotic effect in mouse models of NASH, and there is an ongoing trial in primary NASH. So as take-home messages, NAFLD does not seem to be more prevalent in HIV patients as compared to the general population, but is rising as a leading cause of chronic liver disease in HIV patients. HIV-associated NAFLD, as compared to primary NAFLD, the main risk factors are more or less the same. However, HIV patients do tend to have lower BMI and lower fat mass and higher physical activity, and more aggressive disease with more frequent NASH does occur in HIV patients. So that suggests direct steatogenic mechanisms related to HIV and with ART therapy. HIV-HCV coinfection does not seem to potentiate steatogenesis in this context, and regarding treatment in HIV-associated NAFLD, for now we should do the same as the general population, so weight loss, lifestyle changes, maybe insulin sensitizers. There are several ongoing trials in primary NAFLD, and there are also several trials specifically in the HIV-associated NAFLD group. This is what I had to tell you.